Thank you, everybody, for sticking around. My name is Katherine Chang. I'm an assistant professor of otolaryngology head and neck surgery at LSU Shreveport. I'm a relatively new transplant to Louisiana. I started in September, and I'm really happy to be here. Today, I want to discuss the current landscape of HPV-positive head and neck cancer. This is now one of the most common HPV-related cancer. It surpassed cervical cancer. And now the incidence continues to grow. It's the #1 head and neck cancer that we see. It's surpassed drinking and smoking-related cancers. I have no conflicts of interest. And so I'd like to first talk about some history of how this disease has evolved over time. Before 1990, head and neck cancers were seen in smokers and drinkers. These were patients that were a pack-a-day smoker since they were teenagers, very heavy drinkers, and oropharyngeal cancers. And when I say oropharyngeal cancer, I mean cancers of the tonsil, the soft palate, the base of the tongue, and the back of the throat. Oropharyngeal cancers fell into the same category. It was primarily a disease of smoking and drinking. And surgery was the mainstay of treatment, and back in this time, this was done open, and so we would split the mandible, divide the floor of mouth, move the tongue over to get back to the oropharynx. We would sometimes go through the neck, what was called a lateral pharyngotomy approach, where we divide the pharyngeal constrictor muscles off the hyoid bone and get to the oropharynx that way. And as you can imagine, as you see from these pictures, these approaches were fairly morbid. They caused significant dysphagia, a lot of G-tube dependence, and tracheostomy dependence. Now, the paradigm started to shift in the 1990s with the popularization of conformal radiation. And it's important to note that radiation has become quite sophisticated over the last several decades. When we were first giving radiation to patients, they were literally 2 beams targeting the tumor, and they delivered a lot of radiation to the tumor, but also a lot of radiation to the surrounding tissue. Then came 3D conformal radiation, where we were able to angle these beams more specifically to target the tumor and then spare some of the surrounding tissue. And then moving on to the far right, intensity modulated radiation, or IMRT, which is now really the standard of care for head and neck cancer radiation. Many more beams, many more angles, and this allowed really contouring and conformation to the tumor to target the tumor specifically and spare some of the surrounding tissue. And so this kind of became the standard of care for oropharynx cancer starting in the 90s. Around this time, in the mid-1990s, there was growing recognition that a subset of oropharyngeal cancer patients did not have the classic head and neck cancer phenotype. We were seeing it in younger patients, healthier patients that often didn't have a strong smoking or drinking background. And these patients seemed to have a really positive response to the conventional therapies. We now know that these patients were likely HPV positive. And in fact, the prevalence of HPV has grew from just 10% of oropharyngeal cancers in the 90s to now over 50% of cancers in the 2000s. And that number is even higher today. Now, there was growing suspicion that HPV could be implicated, as it was in cervical cancer. There were many epidemiologic studies. There was one study actually done in Sweden, which found higher tonsil cancer rates in the husbands of wives who had cervical cancer. And so there was already this relationship being drawn that this could be sexually transmitted. It's a ubiquitous virus. So how does HPV actually cause carcinogenesis? HPV actually integrates into the host genome and leads to overexpression of 2 oncoproteins, E6 and E7. The E6 protein binds to P53, which is a critical tumor suppressor, and it prevents cells from undergoing apoptosis, which is a really important mechanism for cell regulation. The E7 protein binds the retinoblastoma protein, another critical tumor suppressor, and this induces cells to persistently be in the S phase during the cell cycle. And so both of these pathways result in genomically unstable cells divide and divide in this unregulated fashion, leading to tumorigenesis. Now, the landmark paper, which really established HPV-associated cancers as having a better prognosis, came from a clinical trial, RTOG-0129, and this study was actually looking to see if accelerated fractionated radiotherapy was less toxic than the standard fractionated therapy we were giving to head and neck cancer patients. But they were able to look at oropharyngeal cancers by HPV subtype, and they found, highlighted in yellow, that these patients had significantly better survival compared to the HPV negative patients. Overall survival at 5 years was 84% if you were HPV positive, compared to only 57% if you were HPV negative. And so as I alluded to earlier, these patients are phenotypically different than your classic smoker, drinker, head and neck cancer patient. These patients are younger, typically in the 40s and 50s. They're healthier, and they don't really smoke or drink. Now, in Louisiana, a lot of HPV cancers are still in smokers, but it's important to realize that these risk factors are not driving their cancer. These are patients that are lawyers, they're engineers, they're accountants. I've even treated other ENT physicians with tonsil cancer. I put up this picture of a marathon runner because I've treated 2 patients now that asked me, after surgery, how long they would have to wait until they could start training for their Ironman. And so it's a very different patient population. And that's what makes treating this disease a slightly different problem. The good news is that their prognosis is better. They have excellent survival. These are younger, healthier patients, better baseline functional status, and they're living longer. But that's the problem. Now the toxicities of treatment are actually relevant in these patients. We're dealing with an increasing number of patients who are living longer and having to live with the very real consequences of treatment toxicity. And so what is that treatment toxicity? Radiation is very hard when you're getting it for head and neck cancer. Patients have significant dysphagia due to the fibrosis of the oropharynx, the pharyngeal constrictor muscles. They can get trismus if they're radiating the muscles of mastication. Xerostomia, as we talked about earlier, that really zaps all those salivary glands in the mouth. Taste disturbance, and then on the more serious side, you get osteoradionecrosis and even vertebral osteomyelitis, which I've seen. And so this is just a picture of what osteoradionecrosis of the mandible looks like. The radiation essentially causes hypoxia in the bone, and they get this demineralization that can actually progress to a pathologic fracture. So there was a need for treatment de-escalation. These patients were responding well to our conventional therapies, but the question became, how can we maintain the excellent survival that we were seeing, but somehow minimize the amount of radiation and the amount of treatment we were giving to improve quality of life in these patients that are now living longer? And so we did try that, reducing the radiation. As I said, definitive chemoradiation was sort of the standard of care. This NRG trial, HN005, was performed in non-smoking HPV oropharyngeal cancer patients, and it aimed to decrease the amount of radiation we were giving. And so they compared standard of care, patients getting cisplatin chemotherapy, 70 gray of radiation, that was the standard, and they're reducing it to 60 gray. They had 2 arms, one with cisplatin, one with nivolumab, which is an immunotherapy. They actually had to stop the trial early because they noticed that in the experimental arm, where they were getting decreased radiation, these patients were having significantly worse progression-free survival. And so the conclusion was that we cannot safely de-escalate the radiation if we were looking to give it definitively, and thus really reduce the enthusiasm for de-escalation efforts in the definitive CRT setting. So we began looking at surgery again. Now, minimally invasive surgery was already getting popularized with laparoscopic instruments and the robot in CT surgery, urology, gyn-onc. And so surgery was kind of moving in this minimally invasive direction. And we too began exploring minimally invasive transoral surgery for oropharyngeal cancer patients. So transoral laser microsurgery, or TLM, was one of the first kind of minimally invasive techniques for oropharynx cancer. You essentially suspended the patient with this metal retractor that opened the mouth, and we use this for tonsillectomies in kids. We brought in a microscope, a CO2 laser, and we were able to cut this tumor out completely transorally. We didn't have to split the mandible, we didn't have to go through the neck, and so it was less morbid. And the rationale was that if we could resect these tumors, we could, 1, maybe get rid of radiation altogether after surgery, or 2, reduce the dose of radiation, minimize some of that toxicity. And the early data on this actually showed pretty promising results. Overall survival, disease-specific survival with this TLM showed 80% at 5 years. And then if you looked at the functional outcomes, they were also pretty good. You had the majority of patients reporting 0 to mild dysphagia at 5 years, and very low rates of G-tube usage long-term. Now, around the same time, the Da Vinci robot was growing popular, again, in CT surgery, gyn-onc, and urology, so, why not the oropharynx? The robot was designed to improve visualization in hard-to-reach areas and operate in hard-to-reach areas like the oropharynx. And so this was actually, Bert O'Malley and Greg Weinstein were sort of accredited as the founders of transoral robotic surgery, or TORS, in 2005 at UPenn. The robot has undergone multiple iterations and is now FDA approved for T1, T2 oropharynx cancers. So the option of minimally invasive transoral surgery, either with the laser or the robot, really re-energized the concept of de-escalation. The question being, if we could get patients to surgery, can we, 1, eliminate chemotherapy and radiation altogether, or 2, reduce the dose of radiation? So this was the first trial actually comparing chemotherapy, standard of care chemotherapy and radiation to TORS, which is like crazy to think about randomizing patients to chemotherapy versus surgery. But they compared patients that got 70 gray of radiation and cisplatin to patients who got transoral robotic surgery, and then they got 60 gray after surgery, and that's kind of the standard adjuvant dose. As you can see, survival and progression-free survival were fairly equivalent between the two arms, so it is at least just as good in terms of disease control. Now, the study's primary endpoint was looking at swallowing outcomes, and they measured this with the MDADI, which is a quality of life measure of swallowing dysfunction. They found that 1 year after treatment, the MDADI scores were actually slightly higher in the chemotherapy radiation group, but that over 5 years, the two curves kind of converge, and there was really no difference in swallowing outcomes. And so this study seemed to suggest that TORS with radiation afterwards was similar in terms of oncologic outcomes to CRT, and probably similar to swallow function, but there wasn't like a big benefit with it. Now, the study's criticized for a couple of reasons. One, at the time that the study was done, we were taking much bigger margins of the cancer with surgery than we're doing today, so that obviously adds to the morbidity, and we're also giving them more radiation than we are today. But in general, the swallowing outcomes with transoral surgery were clearly superior to that of the open approaches. And so we started shifting the paradigm back to surgery for select patients, especially the early stage patients. And so then the question became, that people wanted to investigate was, well, if we do this transoral surgery approach, can we bring down the radiation dose even further? So 3311, this was an ECOG study. It basically took early stage T1, T2 tumor patients who all got transoral robotic surgery, and then after surgery, the patients were stratified into 3 groups: low, intermediate, and high risk. So the low risk patients, these were patients that had widely clear margins, 1 positive node. They didn't get any radiation and chemotherapy afterwards. The intermediate risk patients, these are patients with 2 to 4 positive nodes, maybe a little bit of extranodal extension on the nodes. They got randomized to receive either 50 gray or 60 gray. And so that 10 gray difference, they were trying to investigate whether they could still preserve those oncologic outcomes. And then the high-risk patients with positive margins, tons of lymph nodes, these patients were not eligible for de-escalation, and they got chemotherapy in addition. And so what the data showed was that progression-free survival at 3 years was equivalent in all groups. So importantly, this de-escalated group of patients that got less radiation after surgery had the same progression-free survival as the higher dose radiation group. And swallowing outcomes were excellent across all groups. And so in conclusion, yes, we can safely de-escalate patients down to 50 gray if they get surgery. So we were able to decrease from 60 to 50. How low can we go? The Mayo group has sort of led a lot of the de-escalation efforts. This is the DART HPV trial. They took really that same group of patients, gave them transoral surgery, and then split them into the same risk groups, intermediate and high risk. Now, they reduced the radiation dose to 30 gray in the intermediate risk group, so not 50, but 30. And then even in high-risk patients, these are patients who have extranodal extension. They only gave them 36 gray of radiation. They also gave them 2 doses of docetaxel, which is a chemotherapy, and they compared that to the standard of care, which was 60 gray at the time. And so what they saw was a lot less toxicity in the de-escalated arm, which makes sense. You're giving them like almost half the radiation. So toxicity was 3% in the de-escalated arm, 11% in the standard of care arm. G-tube dependence rates were also significantly lower, 2% versus 8%. Now, when you looked at the patients based off of E&E, or extranodal extension, this is when cancer spread to the lymph nodes, it's gone beyond the lymph node capsule. When you look at the E&E negative patients, de-escalation seemed to work. They had excellent progression-free survival, indistinguishable from the standard of care. Now, in E&E positive patients, you see that blue curve. These patients had significantly worse progression-free survival and local regional control. And so, in conclusion, we could probably de-escalate these patients all the way down to 30 gray if they didn't have E&E. But this was probably too aggressive of a de-escalation for these E&E positive patients. So besides reducing radiation, what else can we do in the de-escalation realm? How about we give no radiation at all? And so the Nectar's trial actually looked at this. They gave patients with HPV positive oropharyngeal cancer neoadjuvant chemotherapy, 2 agents, cisplatin and docetaxel. Then the patients got surgery. They got TORS and a neck dissection. And then none of these patients got radiation afterwards. They demonstrated pretty excellent overall survival, low distant metastasis at 5 years, and good local regional control, very similar to the standard of care. What else can we do? Can we avoid radiating the oropharynx altogether? So in all these de-escalated patients, they were getting radiation to the neck, they were also getting radiation to the oropharynx. And that's where all the morbidity is coming from, radiation to the oropharynx. And so the question was, well, if you get widely clear margins of the primary tumor, can you avoid radiating the oropharynx altogether? At Penn, they conducted the AVOID trial, which prospectively looked at patients that got TOR surgery, and if they had clear margins, 2 millimeters, they were only given radiation to the neck. These patients had excellent progression-free survival at 2 years and almost no local failures. Many institutions like Emory and Penn are routinely not giving radiation to the oropharynx if they're able to get clear margins with surgery. Emory actually published this data. They had 59 patients that received no radiation to the oropharynx after surgery, and they had 0 local regional failures. What else can we do? Can we omit chemotherapy altogether? We've talked a lot about toxicity from radiation, but chemotherapy can be pretty toxic for patients as well. They get sick, they vomit, they don't eat, they're fatigued, their white counts can plummet, and we conventionally always give it for extranodal extension. The PATHOS trial, which is being done in Europe, is looking to see if we can omit chemotherapy in TORS patients who have positive E&E. The results of that study are still pending. So more recently, we have shifted towards TORS with de-escalation of radiation and chemotherapy in select patients that are lower intermediate risk. What else is on the horizon for HPV? And so immune checkpoint inhibition, you can't really have a head and neck cancer talk without talking about immunotherapy. But the immune system plays a critical role in head and neck cancer, and disruption of immune surveillance results in tumorigenesis in a lot of head and neck cancers. And this is really due to exhaustion of T cells, inhibiting their cytotoxic activity. Anti-PD-L1 inhibitors take advantage of this interaction that tumor cells have with T cells, where when the PD-L1 receptor binds with the PD-1 on T cells, they actually impair T cells' ability to recognize cancer cells and kill them. And so a lot of anti-PD-L1 inhibitors, anti-PD-1 inhibitors block this activity and thus activate T cells to target cancer. Now for HPV, immune checkpoint inhibitors are primarily used in the recurrent and metastatic setting. They're not really being used at this point as primary or neoadjuvant treatment, but that's certainly where a lot of the trials are headed. So the OPTIMA trial, this was a phase 2 non-randomized study that was done in University of Chicago, looking at stage 3 and 4 head and neck oropharyngeal cancer patients. These patients got neoadjuvant nivolumab, which is an anti-PD-1 inhibitor, carboplatin paclitaxel, which are chemotherapy agents, and after they were treated with this neoadjuvant package, they were given risk-adapted treatment. They found that 70% of patients had at least a 50% tumor shrinkage with the regimen, and that resulted in 86% of patients getting de-escalated local regional therapy, and they were able to maintain pretty excellent progression-free survival. Now, it's hard to know whether this was all due to the immunotherapy because they also gave chemotherapy, but it appears that immunotherapy probably has a role in the neoadjuvant setting in helping us further de-escalate treatment for these oropharyngeal cancer patients. It's also been investigated in the adjuvant setting, in the maintenance setting. EA3161 is a clinical trial that basically looked at giving intermediate risk patients who were getting definitive chemotherapy and radiation, then giving them nivolumab after CRT for 1 year. This trial is currently closed to accrual, and they're doing their analysis, and that's pending, so there's more to come there. There's also been a lot of focus on the HPV vaccine. It's now being recommended prophylactically for males and females during their reproductive years to prevent a lot of these HPV cancers. But there's also been a lot of interest in investigating the HPV vaccine in treating HPV cancers in combination with immunotherapy. These vaccines contain inactivated oncoproteins like E6 and E7. And so when you get the subcutaneous injection, these proteins are taken up by antigen-presenting cells, and they induce memory in the T cells so that the T cells can go specifically target HPV tumors. They combine this with immunotherapy, which again activates T cells to target tumors, and the thought is that these two things can synergize one another and make immunotherapy more effective. There was a recent JAM Oncology publication in 2019 that looked at the combination of an HPV vaccine with nivolumab and immunotherapy. And they did see, and this was an incurable head and neck cancer, 92% of these patients were oropharyngeal cancer patients. They observed an overall response rate of 33% in 24 patients, and 2 of these patients actually achieved a complete response. And so still a lot of ongoing research in this realm. Now I want to shift gears a little bit and talk about circulating tumor DNA. This is an incredible biomarker for this disease. They can actually measure the amount of HPV in the bloodstream. 80 to 90% of patients will actually have detectable HPV DNA in the bloodstream if they have oropharyngeal cancer. Why this is important? It helps us monitor these patients after they get treatment because that level should theoretically fall to 0. Now, the majority of head and neck HPV patients, when they fail, they're going to fail in the lungs. They actually don't fail in the neck or back at the primary site. And this makes it very difficult to monitor because I can look in the back of the throat, I can scope them, I can feel the neck, but it's really hard for me to monitor for distant metastasis and catch it early. And so ctDNA has actually allowed me to actually catch these recurrences faster. If they have a positive ctDNA, it really lowers my threshold to order a scan. Now, in addition to being a great tool for surveillance and monitoring for treatment response, there's been a lot of interest at looking at HPV circulating DNA as a risk stratification tool. Can we de-escalate patients if they have a negative ctDNA after surgery? So Emory actually conducted a phase 2 trial where they did just that. They took these intermediate risk oropharyngeal cancer patients who got surgery with TORS, and they had to have a detectable HPV DNA, obviously, at the time of diagnosis. 2 weeks after surgery, they then drew their ctDNA. Those that had undetectable levels were considered low risk, and they got de-escalated to 36 gray of radiation. If you had a detectable ctDNA at that time, you got the standard of care, which is 50 gray. In their interim analysis of 30 patients, 90% of patients actually cleared their ctDNA after surgery. The local regional control was 96% at 12 months. Progression-free survival at 12 months was 89%. They had 2 deaths that were unrelated to the cancer treatment. So it appears that, yes, we can further de-escalate patients if they have a negative ctDNA after surgery. The long-term analysis of this trial is not available yet, and they're currently in the process of making this particular study a national cooperative trial. So what's next for HPV oropharyngeal cancer from a clinical trial standpoint? Now that we're better at TORS, we're taking smaller margins, we're doing it more minimally invasive, there needs to be a new trial comparing CRT to TORS and specifically looking at dysphagia outcomes of both modalities. Do patients with extranodal extension need chemotherapy? We talked about how de-escalating their radiation was definitely a no-no, it was not safe, but do we need the chemotherapy? Pathos 2, which is that ongoing trial in Europe, will hopefully illuminate us on that question. Is there a role for immunotherapy beyond the recurrent metastatic setting? Can we use and leverage immunotherapy for the treatment of this cancer in the neoadjuvant and adjuvant setting, hoping that we could further de-escalate patients? What is the efficacy of combination immunotherapy in these HPV vaccines? And then can we de-escalate patients based on their HPV DNA? And so in summary, HPV oropharyngeal cancer patients have an improved prognosis and better survival than our average head and neck cancer patient. Treatment should be focused on minimizing treatment toxicity while preserving oncologic outcomes. TORS surgery allows for safety escalation of adjuvant treatment in early stage disease. And the role of immune checkpoint inhibitors in vaccines, it remains unclear, but certainly further research is needed. That's all I have. Thank you guys so much.